to today's webinar. We're really excited. We have Hillary Krystiniak here from the Hospital for Special Care in New Britain, Connecticut. Hillary is a BCBA, a board-certified behavior analyst with a decade of experience in the field of applied behavior analysis. Currently, she's working in a leading hospital specializing in developing and implementing behavior intervention plans for patients with autism spectrum disorder and other developmental challenges. At the hospital, Hillary collaborates with the multidisciplinary team to provide comprehensive care, ensuring the behavioral strategies are integrated into each patient's treatment plan. And she's going to be telling us a little bit about that today. She's passionate about advocating for her patients and believes in the power of tailored, evidence-based approaches to foster growth and independence. Thank you so much, Hillary, for being here today, and we're really excited to see what you have to present for us today.
Of course, thank you for having me. Right. Hi, everybody. I'm just going to pull up my slides for you.
Oh, and while you do that, one more thing I forgot. We do have a Q&A box. Sorry, guys. It's DC Planning Week. My brain is not here today. We do have a Q&A box. Please put your questions there so we're able to see them, and then use the chat for your general conversations that you have throughout this. It'll make it a lot easier for us to find the questions if you use the Q&A box for those. Thanks.
All right. So I'm just going to jump right in. I'm Hillary. I have been a BCBA here at the Hospital for Special Care for 4.5 years now. So I know it pretty well. I've seen a lot of evolutions, and I'm really excited to talk to you guys about what we have and what we do, and kind of answer how we can help you. So today I'm really going to be able to talk to you guys about what an acute inpatient stay consists of, and have knowledge about the collaboration that we have across our providers that we have. I'm going to let you know all the providers we have, all the services we have, and I would love for everybody to have an understanding of the interventions we use, and how we can generalize those across settings. Something I get asked pretty regularly from my families is, how do I make what you're doing here happen at home? And that's a hard question to answer, but I'm going to try to answer it for you guys and say how we generalize these to home. So we are the 4th largest freestanding long-term acute care hospital, which is a mouthful, in the US. So we're pretty unique in what we do, not just in our inpatient facility, but in the hospital as a whole. So this is just a list of all the other things we do in the hospital. Our unit specifically is kind of different than the rest of the hospital, but we do have a lot of great care throughout the rest of the hospital as well. So the Autism Center specifically has 3 programs. We have our outpatient services, our partial hospital program, and our inpatient care. And this is really kind of a trifecta of success, because we're able to have a lot of collaboration, step down, kind of giving everyone what they need as much as we can, especially with the understanding that services are limited right now. It's hard to find services. So this kind of wonderful trifecta gives us a lot of success to be able to help families and collaborate. So our leadership program, or our leadership in the program, is run by our 3 top tier psychiatrists and our psychologist. Sabu Mubashar is the inpatient medical director. So he is the person running the medical show on the inpatient unit. I have worked with him for about 10 years now in various settings, and he has been wonderful to work with. He really knows his stuff. He's really very helpful for families and loves to work with families for that input. Dr. Minhas is our Chief of Autism Services. He also runs our partial hospital program and our outpatient program. So he oversees those 2 programs and collaborates directly with Dr. Mubashar for any kids that are transitioning from one to another. Dr. Herlihy is our director of autism psychology. She oversees the behavioral team directly and jumps in when necessary for any kind of family-led therapy that might be needed, which is wonderful to have her on. She also is one of our leaders on our outpatient side to do ADOS evaluations, which I think we all know there's a huge wait list everywhere to get an appropriate evaluation. So she's one of our leaders for that in our outpatient. We have a huge team, and I would say this is the main reason we are successful here is because we can do a lot all at once that no one else can do. We have 5 speech pathologists, 6 social workers, 2 psychiatrists, 3 psychologists. I believe we have another psychologist since I made this. 5 occupational therapists, 3 BCBAs, 6 APRNs, 1 physical therapist. Name another place that has that many people in one setting that all work together. It's amazing to be able to collaborate. I would say inpatient, one of the biggest collaborations we do is with speech pathologists to get AAC devices. So something that we have been working on here inpatient is how can we work with insurance to quickly get these kiddos that really need communication, the device they need to start teaching it. And outside of here, it's hard to get all of the evaluations you need and everything, that the insurance is looking for. So we do that process here for you when it's possible. Also, our occupational therapists, they work very closely with us to put in any sensory needs to be able to help body regulation and how can we help this kiddo outside of here where there's much more stimulation stay regulated. So we all work together, which is really nice and fairly unheard of in the behavior analyst realm of things, let's be honest. But this has been a wonderful collaboration. So what we do in our outpatient a lot is the assessment piece. So we do a lot of the assessment and diagnostic services. The ability to get on our waitlist or send in any of the kind of requirements is on our website. So you can always pop over to our website and it has all of the forms you need to be able to get on the list for these assessments and diagnostic evals. We have medication management and psychotherapy, which is wonderful. Physical, occupational, and speech therapy are all in our outpatient as well. So you can have outpatient occupational and speech therapy, physical therapy. They do a lot of co-treating to be able to get the most bang for your buck, which is amazing. And family and caregiver engagement. So we do offer with our psychologists and social workers education for children and their families, which I think is a huge missing piece is getting the whole family involved. It's not just the child that's having to work through this, everyone is. So that's a really big piece of what we do as well. So our length of stay for inpatient is typically around 4 to 6. Oh, I'm sorry, this is our partial hospital program. Same thing though, it's typically around 4 to 6 weeks. And it's, there's 2 cohorts. There's a morning cohort that we have that goes from 8:30 to 12 p.m. And those are usually younger children, ages like 4 to 10-ish. And the afternoon program is for the older children up to age 21 who are a little bit more verbal, able to engage in social emotional learning, and do a lot of group-based activities in that chunk of time. So it is a small group therapeutic environment. It's led by, again, a whole host of workers. We have social workers, OT, speech and language pathologists, all running groups. We also have a BCBA who runs behavior plans, their parent trainings and group activities, and APRN and a psychiatrist, as I said, Dr. Minhas, who continues to do medication management. So med changes can be done while in program as necessary, which is really, again, a wonderful a wonderful option. Not all partial hospital programs, A, are autism specific, or B, offer that psychiatric piece to be able to do med changes. There's the parent and caregiver involvement is essential as well. So our inpatient does it, our partial hospital does it. We do have parent trainings with the BCBA or the social worker in the partial hospital program to work through what is happening outside of the program. So, your child is here with us for 4 hours. This is what we're seeing. What are you seeing? What can we help you with at home? How can we make this successful, not just in the 4 hours we have them? They do a lot of the parent training piece for that too, and involving families. If a sibling is having a hard time or is a target, let's bring the sibling in. Let's work on it all together. Any extra caregivers, let's work on it all together. So they definitely do a wonderful job in that piece. The parent training for the partial hospital program is only one time a week. So now onto our inpatient program, kind of my specialty. So this really is for individuals who need advanced medication changes or some pretty serious behavioral modification for safety. Individuals who have extreme aggression, extreme self-injury, property destruction, suicidal ideation, kind of the whole gambit we take in for our inpatient and work through it. So we do have a large range of the abilities we have here, and we work through all of them. The average length of stay here says 30 to 40 days. It's closer to 21 to 45 days for several factors. One could be insurance. Unfortunately, I always have to give that caveat that insurance is a factor in length of stay. But the other factors are medication changes and behavioral changes and how much success we are having. We don't want a kiddo to stay here longer than necessary. If we've seen really great change in 21 days and the meds are done, we don't want to keep them in this facility for that long. It's a hospital. It's not the most favorite place to be. But if we need to continue working on things, we do, have longer lengths of stay up to about 45 days. Usually the kiddos that come to us have exhausted care in the community. They have done the in-home, they've done the clinics, they've done all of the things have been tried and change just isn't happening, or it's gotten worse, or, hey, we were doing really, really great and now this huge spike happened and I've been in the ED 3 times in 3 months and what's happening? We need a better look at it. Those are the kids kind of in crisis that are coming to us. Our unit does have Dr. Mubashar as our psychiatrist. We also have an APRN. We do group-based interventions, 24-hour nursing care, and behavior interventions with myself, our support staff, and our behavior assistant. We also have parent trainings, which are twice weekly in person, and I'm going to get into those a little bit more later in this. All right. So I think what I get asked a lot from families who are coming in is, what are you doing on the unit? What is your structure of the day? What will my child be doing? Are they going to be sitting there? Are you going to be engaging with them? Are we going to be triggering them? What are we doing? Our unit is, I actually had one family call it a unicorn because they've never been anywhere that has the structure that we have for an inpatient facility. That's probably pretty true because we do run a strictly ABA program. So it is very structured. Our kiddos wake up at 7:30, they go to bed at 8 o'clock, and the day is split into 30-minute chunks. So they are changing activities every 30 minutes. That is not something that's plausible for a home, but here we can really toss it on them, really get them used to that structure, and then, fade back to what would be more successful in a home setting. Um, so they are small groups run every 30 minutes outside of snack time, lunchtime, things like that. And we do have groups that are run by OT, speech, certified therapeutic recreation specialists, and our activities coordinator. Um, all of these groups they do are wonderful. And it also means that every patient gets interaction with our OT and our SLP, even if they're not getting direct care. So they're able to say, hey, Hill, this kiddo, it seems like they were scripting a lot. How do we change the scripting to be more functional? Even if they're not doing direct care, they're getting that intervention from a speech or an OT, which is amazing. We do have academics twice a day. We have Learn Well come in, who is a wonderful tutoring service, and they do 45-minute groups twice a day based off of what the school district your child is in sends them. So they reach out to the school district sends them either an IEP or some work to be done, and they do that with the patient to try to keep them rolling along academically as much as they can. So we are not a one-to-one facility, which means most of our kids are in a 1-to-3 ratio, one staff to 3 patients. So during these academic times, during these groups, it's 3 patients at a table with their staff, working through socially what needs to get done, increasing their independence and work compliance. We do have one-to-one staffing available. We really only utilize that for kiddos who have extreme self-injury, pica, mouthing, things like that, because the setup of our unit doesn't need that. We're set up to be able to increase independence by not having those one-to-one services. So most patients, as I talked about, are coming to us in crisis. What does in crisis mean? This means the behaviors are unmanageable in the current environment. It's different for each patient, but it is no longer safe for them to be where they currently are. They are having meltdowns that are causing major property destruction, injuring themselves. The threat of injuring themselves is very high. So they're coming to us kind of at 10 out of 10, and we're having to work them down to their baseline from there. This means that we are literally starting at crisis management and then putting in intervention. So first thing first, we're getting all parties involved. Myself, OT, speech. We all do our evaluations to see what's safe, what's going to be successful, are we programmable, where are we at? Our psychiatric team sees the patient immediately as well, gets a good read on things, and will call the families usually pretty quick after intake, maybe 3 days or so, with a plan for medications. So we are really immediately just starting in crisis management, bringing the patient to a safe place, and then getting programming started for them. In that crisis management, they are still interacting with peers, with the group demands. We're maybe not pushing it, but they're still aware of it, so they know what the expectations will be. I say this, and then we have kids come in that have been in crisis in the community, and we see no behaviors, and everyone's like, what just happened? How is my child not having a behavior there? It does happen sometimes. If there's no behaviors, we do try to elicit a behavior so that we can work through it. What is a trigger for them? Let's put these triggers in place so that we can practice how to be safe with them. If not, then we just try to continue on with what we can do, increasing structure, working with families through, what was happening at home, and seeing how much success we can get in changing a home behavior, if you will. We do some assessments on the unit. I will say they're pretty fast because of the length of time we have. So we have FBAs. We do our functional behavior assessments as BCBAs. I don't have very long to do it. I usually can get it done within the first 48 hours of a patient being here. And that is, I'm evaluating the inpatient function. I'm not able to evaluate the home function of behavior until I've talked with the family at a parent training. From there, I can kind of work to hypothesize the home function of behavior and is it the same as what it is here? Sometimes it's different. At home, sometimes the function is attention and here it's escape. But we can, once we know there's a difference, we can work through that in both parent training and on the unit. If necessary, I do a functional analysis. Usually we don't really need to do that because we see pretty quickly the behaviors. Speech does feeding evaluations for picky eaters. We have a wonderful speech pathologist who is able to do desensitization on the unit for picky eaters. And we also do those AAC evaluations as well. OT does their activities of daily living assessment. They assess everything from how they get out of bed to how they get dressed to how they brush their teeth to attending to be able to sit in a chair, which is amazing to see. And then they do a sensory evaluation as well. All of these evaluations are available to the families once completed. So you have them, you can give them to whoever needs them. We review them with you as well. So you can kind of see what we're seeing and tell us like, oh, this is what we see at home, or no, this is not what we see at home, which can be very helpful. So parent trainings are hands down the hardest thing about our program for families. They're hard because A, they're only twice a week and they're only for 1 hour. And B, I'm asking you to do things. You're seeing your child, all you want to do is hold them and hug them and love them. And I'm saying, I know you want to do that, but we have to work through things that can be really difficult before we can have that time together. So it's 2 parent trainings with a BCBA or our behavior assistant. And it's really working through these tough behaviors that have been happening at home, showing you what we've been doing here and helping generalize that to you, to generalize that to home. So the first parent training is a 30-minute functional interview and then a 30-minute interactions assessment, which is really when we go on the floor and we just see, how the patient reacts to you being there, to you leaving, how to your prompting style, any of it. And then we also do education in these parent trainings as well as to the interventions we're doing, but also anything that we have seen, any new behaviors we've seen or any needs that we're seeing, any deficits we're seeing, we address those as well. Frequently, the education I'm giving is language deficits that have been missed by our verbal individuals. Kiddos who are verbal, people think like, yeah, they've got it. They know what they're doing, but really there's huge language deficits where they're masking all day and then they're having these major behaviors because they don't actually know what's happening, and now they're exhausted and frustrated and they've come to their safe person, which is you, and they're losing it. But school is telling you, hey, they had a great day, what are you talking about? So that is frequently an education that we do give. So we kind of have 2 types of parent trainings that we do. The first is a behavior skills training model where I am reviewing everything with you. So I'm showing you the plan, showing you the interventions, modeling it. The families are then practicing it and continue, rinse and repeat. That's what we're doing. So that is one, and that's for our individuals who are needing those AAC, modeling how we're using the AAC, modeling blocking and redirecting, modeling the de-escalation techniques we're using. All of that is kind of more for the behavior skills training that we do. And then on the flip side of that, we do have behavior contracts that we do. So we do a lot of, for our more verbal kiddos, we do a lot of what the expectations are going to be when you go home, electronics restrictions, earning procedures. What is a parent responsibility versus a patient responsibility? Because a lot of times our patients kind of like to say, well, that I didn't need to do that. Yeah, you could pick your clothes up off the floor. That's something that can be your responsibility. And it's a great skill to have. Scripts to help with de-escalation, scripts to help with increasing coping skills, and schedules to increase structure in the home. So these are the two types of trainings we do. I wouldn't say one is harder than the other, but they are very different in what we do. So the collaboration piece, we collaborate with families twice a week. We're working with you guys, we're seeing what's going on. But the collaboration with the outside providers is quite essential as well to help that generalization. I say this knowing it is incredibly hard to find a provider as it is. If you add a kiddo who has any sort of severe behaviors, it's even harder to find a provider. Somebody that's going to come into the home and run ABA, it's hard to find. I'm not going to deny that. But if we can get one in place while you're here, or if you already have one, we jump head first into that. We are really looking at that in-home ABA to say, hey, help me help you. This is what we're seeing here. How can I help you change the plan to be successful to home? And how can we maybe start running that here so that we can have that success in the generalization piece? Usually with in-home, we're meeting them 1 or 2 times. Either it's Zoom, telehealth, sometimes they come in person. I had a provider come all the way from like the middle of nowhere, Pennsylvania, drove up for a whole weekend to be able to work with us. I was like, this is incredible. And we review everything. We review the behavior plan, the data, how the trainings are going, any education we've given to the caregivers so that everyone's on the same page. We also recommend if the in-home can come with a caregiver for one of the parent trainings, awesome. We are starting that collaboration together now, getting everyone on the same page. We're going to review the skill deficits and assessments that we've done. And when a new provider is found, we always encourage collaboration before they even start. So it's a new provider, you need an assessment, come to the unit and see the patient, meet with me, I'll give you the behavior plan, whatever we can do to help get this jump started before the patient is home. How can we get this set up as quickly as possible? We collaborate with schools as well. I would say schools are almost our hardest to collaborate with because they have such limitations as to what they can and cannot do. But we meet with them, we review everything like I talked about. It's the same, reviewing the behavior plan, the data, the parent trainings, any education, the skill deficits, the assessments. We're reviewing all of that with the school as well. The one kind of caveat to this is we're not an academic placement, so we cannot make academic recommendations. So I can tell the school how successful somebody is being in a small group with specific instructions, but I can't say, hey, we recommend they go to an outplacement facility. Because I'm not an academic placement, they're going to say, well, what do you know? Like, well, I've just seen them for 24 hours, 7 days a week, but that's kind of the limitation to being able to give those recommendations. We also encourage the school to come out and see the patient as well. Come see how they're doing. Come see the changes that have been made. You were on the fence about being able to keep them safe in your environment. Come see where they are now before you make that decision. And the last collaboration we do are provider calls. These are in the 3rd week of stay. It's this quick Zoom meeting, about 30 minutes with our whole team, plus the whole outside team, plus the families to touch base. Does everybody have what they need? Where are we at? In home, are you ready to start? Provider, are you gonna, take this patient back upon discharge? Try to get all those questions kind of answered and try to help ease the families mind that there is a plan upon discharge. It's not going to go willy-nilly. So the number one issue that I run into that is a question I get all the time from families, from providers is what are we doing here? Like, you're a locked unit. They can't elope from you. It's not a home. A hospital is not a home. How do we take what you're doing with your 3 shifts of staff and your locked doors and make it successful? That's hard. What we do is not always replicable. I can't deny that. So that is where we do try really hard to collaborate with families, outside providers on that kind of how can we bounce ideas back and forth off of what we've seen to try to help you with this issue at home. So we can't practice things like transitions from or to cars or vans, school refusals, or elopements. Those aren't things we can necessarily practice. What we have kind of more integrated, because this was an area of concern for many families, was sibling involvement. So we used to be very, very strict on our sibling policy, and we have really listened to families, listened to the feedback, and we hear, hey, my kiddo, the sibling is under 12, but they fight all the time. I need to be able to connect them while they're here. How can we put this together? And we have been able to really come up with some creative ways to bring that sibling involvement in to help with that issue at home that isn't necessarily something we can work on here. So we're doing our best to evolve and help as much as we can. But those are some things that really are hard for us to work on here. But we're going to do our best to fade, to collaborate, and to bounce ideas off of everybody. So you're saying this is a problem. This is what I'm seeing here. How can we help it? So some things that we do on the unit that are very helpful, easily replicable, easily generalizable are visual schedules and token economies. These are clearly something I think everybody knows and has probably done 1 or 2 or 17 times. But we do those a lot. We try to help make schedules for home, try to help make the token economies for home, start them here so that they're more easily generalized to home. We do a lot of competing stimuli for our kiddos that have intense SIB. One of my favorites is we have these Bluetooth headphones, and I have found music has been incredibly effective as a competing stimuli for some hand-to-head SIB. It's super simple, easily generalizable. We do a lot of discrimination training for attention-maintained behaviors, just teaching when something's available, when something's not available. Increasing leisure activities is huge. A lot of our families come in and say, I don't even have a minute. My child needs me next to them 24/7. What can I do? We're going to increase some leisure activities and make them more independent. Differential reinforcements and functional communication. I would say the biggest intervention we do on this unit is functional communication. It's huge. I've never once had a family come in and say, I want my child to not be able to tell me what they need. And the child has always had more success once they have that language. So I got a couple kind of case studies to kind of just wrap around showing everything we do and examples of kind of different type of kiddos we work with. So our first case study is a nonverbal patient who presented with severe self-injury in the context of transitioning from technology, ritualistic behavior with technology, and he had severe problem eating. And when I say severe, this kiddo had less than 5 foods that they would ingest. Incredibly picky eating. While inpatient, our speech pathologist did some amazing food desensitization sessions. They were able to work with the family to do the food desensitization. So one parent training a week was with our speech pathologist, strictly doing feeding, strictly saying, hey, I'm going to show you what he ate this week, and he's going to eat it with you so that he'll maybe eat it at home. And she also did a wonderful AAC evaluation, was able to get him a device while he was inpatient with us and start teaching that, which actually also helped with the food desensitization once he found the food page and could ask for things he wanted. We had an individualized behavior plan in place, one-to-one schedules with dense reinforcement, getting them used to having to do something other than their rituals, trying to put in place replacement behaviors for these ritualistic behaviors that were now impeding their ability to function, and visual supports. First, then schedule and a daily schedule. OT did extensive ADL skills for teeth brushing and increasing independence in showering, and a lot of sensory input. They had a lap pad, a weighted lap pad that helped with hand to hip SIB, a rocking chair to get that input safely instead of rocking against things that were hard. Parent trainings, like I said, once a week was speech and once a week was practicing the behavioral interventions. And the in-home ABA team came for, I want to say, 6 trainings in total, split between myself and our speech pathologist. And this kiddo just strived, at discharge was looking significantly healthier, happier. It was wonderful to see what we could do and what we could send home and how we could help, just especially with the feeding program that was put in place. I think that was the highlight of this patient's stay, was the feeding that we were able to put in place for them, which is huge. It's huge. Another quick case study is a verbal patient who was referred for ADL and school refusals, had suicidal ideation and verbal threats. So this is very different than our last patient, very different, but we still put in the same level of care, looking at all the disciplines of what can we do? What is causing these behaviors? How can we help that deficit? And through multidisciplinary assessments, we found that this patient has what we refer to, this is not a technical term, we've learned that this is an autism inpatient unit term of cocktail party language, where they had great surface level language. They could talk to you all day about the things that were surface level, baseball, basketball, the questions you're supposed to ask. Anything beyond that, they did not have language for, which means socially, they were struggling immensely keeping up with peers because they could not follow what was happening, which was leading to embarrassment around peers, leading to school refusals, feeling bad about themselves. That's where this all was stemming from. And we were able to identify that where the school had not identified that. And we were able to present that to the school. So speech did group activities to increase appropriate language. Speech also did the speech evaluation. I can't remember exactly which one she did, but she did an evaluation that we were able to use to send to the schools. We had an individualized behavior plan in place for task completion and ADL completion, with dense reinforcement for both of those, and a lot of task analyses to increase independence. Because again, with that cocktail language, they just didn't quite understand the processing of what do I have to do next, which made it look like they were much less independent than they were. So putting in those visual supports in a task analysis, they ended up able to do their entire morning schedule independently upon discharge because they had those visuals in place that we were able to send home with them. And our OT did ADL skills with them, again, to increase that independence and that ADL compliance piece. Parent trainings, one session a week was a behavior contract, and then one session a week was ADL skills, because we found there were also ADL skill deficits in understanding, again, the task analyses of what comes first, what comes next, all those types of things. And the collaboration piece for this kiddo was huge because we were able to get the school to come out after we sent them what we saw and do an assessment for placement and place them, start the process of placing them in a more appropriate setting. We were able to help with that, give them all the information we had, and this kiddo was outplaced to an appropriate school within a few months, which was wonderful to see. That home services also was able to meet with us to do the behavior contract, tell us if it was feasible at home to do, does it fit with the goals they already have in place, and how does it meet the family's goals for home as well that had already been discussed. So just a couple really good things that we were able to do and have success with. And the last case study, again, very different from the other two. I just kind of wanted to show the range of what we're willing and able to work with. Is that the patient presented with scripted perseverative language and rituals that were really inhibiting the ability to engage in daily activities and leading to severe self-injurious behaviors when they were unable to complete the ritual. If something got in their way so that they weren't able to complete the ritual, instant hand to head, head to wall, and these rituals were incredibly long in nature. And that was where it was becoming, they couldn't complete them because of the length of the ritual. So speech put in an AAC evaluation, which was wonderful. The individualized behavior plan is really kind of what shined through this time, which was a lot of replacement behaviors for these rituals. So we put in place different reinforcement for verbal perseverations, having them read out loud or answering grounding questions, which also gave really good interactions with staff, with parents that were positive, and then you were able to build off of. Physical rituals, we did a lot of heavy work with to kind of break those and give some different input. Increasing leisure skills to increase the structure of home and using that music for competing stimuli. The parent training sessions were twice a week and they were DRI procedures. So they were all the procedures we were putting in place for replacements for these rituals. And by discharge, family was running these procedures completely independently. It was amazing to see. We met with the school multiple times, was able to show them everything. I actually was able to go out to this school, which was amazing to see. And the patient did not have in-home services at the time of discharge, so we weren't able to meet with them. But those are kind of three different sets of what we do here and all different types of behaviors. Just kind of to show what we can do here and what we do here. But that is kind of the kit and caboodle of what we do. Are there any questions, anything you were looking to hear more about?
Thank you so much. And I don't know what's going on with my video. Huh. I apparently don't have a video right now. I don't know why. I think my webcam must have got hit. But yeah, so if you have questions, please go ahead and put them in the chat. Listening to you, and a lot of our viewers most likely are going to be very familiar with the terms, especially if their child's in crisis. They've gone really round the gamut probably with ABA. But just in case, especially for anybody who's maybe watching this on replay on YouTube and isn't as familiar, can you go more into a little bit explaining a little bit of the jargon, such as generalizations or differential reinforcement, DRI?
Sure. So the generalization, what I'm talking about is taking what we're doing here and bringing it to home or a different environment or a different person. So a lot of times our individuals will become very successful with an intervention we're doing here, but they won't be able to do it at home. And that's where it becomes, hey, what happened? So that generalization is being able to bring it from here to home or school or the community successfully. And the
Right.
DRI procedures, those are called differential reinforcement of that was an incompatible behavior. But generally, a differential reinforcement is that you are teaching and reinforcing a new behavior, a new safe behavior over the unsafe behavior of whatever it is the patient is engaging in. So it's really just replacement behaviors that are safer and able to be continued kind of anywhere besides here for that safety piece.
Right.
I
Great.
can't remember the other jargon that I had in there.
No, I was just trying to note some that I thought maybe people might, because I do the same thing. In fact, I do it all the time. I use acronyms. I really try not to, but you know, it's just we do it. But there's a question that says, "Wow, in those 3 case studies, you described my 3 children with ASD. Can I get in contact with you to see if you can assist us?" How would people get in contact with you if this sounds like a good program for them?
Wonderful. I love to hear that you want to get in contact with us. So our main point of contact for intake is Kayla Santiago. If you go on our website under the inpatient tab, all of her information is there along with the forms that she would expect. But you can always call Kayla, get some more information about the program, and be able to talk to her about, is this a good fit? When would we be able to get in? What is it that you need? Um, but I can definitely send Jackie the information for Kayla and our outpatient facility as well to be able to send out.
Yeah, and I do believe that Hospital for Special Care is on our website, under inpatient services, and I will check to make sure Kayla's information is there. That's probably where we'll put that for you guys, but, and maybe link to that from the webinars page too, just so you can all find it. Um, Additionally, so obviously Connecticut's super tiny, and you service a lot of individuals from a variety of other states. And what I find is really unique is that you're doing that, yet there is this in-person parent training. So can you talk a little bit about the logistics of that? In your experience, how are parents managing that for that stay?
So there's a couple different ways. We do have free housing on our campus for families. So we do have a guest house that families can stay in for the duration of the patient's stay here. There are some rules to it. I can't remember off the top of my head, but we do have that available to help with housing. We also have families that will come and do, if they're close enough by, they'll maybe do one in person and one virtual if that's available, or they'll switch off what parent is here for them. But we do have that free housing to try to help with that because we understand that travel is really hard. You can't be flying back and forth. I've had families from Texas, I've had families from Wisconsin, Nebraska. You can't be flying back and forth all the time. So we do have that free housing available, which is a really wonderful feature.
Yeah, and just for anybody who might be thinking about it, I myself was looking out of state years ago, and in New Jersey, actually at your facility, multiple different places for my daughter. And because you service under 21, anybody who has Medicaid or a waiver under 21 has EPSDT protection. And one of the great benefits of that is if your child does have to go out of state for treatment, you can talk with your Medicaid administrator. They oftentimes will offer a small per diem, a daily per diem for families to stay local to the child, especially if there's parent involvement as part of the treatment, right? So that is another avenue to make sure to talk with your Medicaid administrators about.
And our social workers also work with families' employers to fill out FMLA forms or give any notification that's needed for the employers. Some employers just want a letter saying, like, these are the days they're here, and that's plenty for them. But they do work with whatever is needed for the employers.
That's super important, super important. What is your return rate? So say somebody exits your program and they're doing good, but 6 months later they have a regression. Are they allowed to return? And do you have a sense of how often that may happen?
So they're definitely allowed to return. We do have some patients that do need to come back for a medication tweak, especially if they've been here before puberty. And then I think everybody here can talk about puberty is just
Yeah,
the worst.
it is.
It's the
It
worst. And then, puberty hits and they're like, hey, we had 3 really, really good years and I don't know what just happened. Puberty hit, meds need to be changed. Come on back. We can definitely assess that. Even if it is 6 months and something needs to change, you can always be readmitted. It's the same process as the first time going through Kayla, getting all your stuff. It's a little bit simpler because we already kind of know the background. I will say I don't have the direct numbers in front of me, but our readmission rate is fairly low compared to other facilities. Part of it is because of the parent training piece and the collaboration we do does help with that success at discharge.
Do you have a number? So say you're looking for a 50% reduction in behaviors or a 70% reduction. Do you have a number that you consider that patient is ready for discharge based on the baseline that they came in at?
It varies per patient. So we do have um, weekly interdisciplinary team paperwork that we fill out. It's on our EMR and it does get sent to the portal. So families have access to the portal, Follow My Health portal while their child is here, and does have access to like the nursing notes, the parent training notes, the interdisciplinary notes. And in those interdisciplinary notes, we do put individualized goals for each patient that we're looking for. A certain reduction in self-injurious behaviors, a certain increase in functional communication. So we do look for that individualized across patients.
It's great. It sounds like you have really good communication with the parents, which is super important and critical for
We
these
try
families.
really hard because we know how difficult this is.
Yeah, yeah, it is. It is challenging. I mean, many of us have been there. And there's such a need for this in the nation. There's very few, like you said, there's very few places that specialize in autism care. And and especially at this time period, adolescence is, unfortunately, autism doesn't seem to hinder adolescent hormones. We get all the problems that were happening already, but add on teenage hormones to the mix, and it can be a wild ride for several years there. And it's really important that families know what options might be available to them. Um, if there if there's a family that say they come and is 6 weeks your time limit or
No. So
okay.
we don't have like an expiration date is what I call it. That's kind of our average length of stay. We do find that because of how locked down our unit is, too long is too long. But the end date is based off of, on our end, success. So if we're seeing success and it took a little bit longer than 6 weeks, then it took a little bit longer than 6 weeks. Um, the one caveat to that is insurance. Insurance's definition of success is certainly not our definition of success.
All right.
So
We
that sometimes does hinder the length of stay. Again, we try to tell families when we are starting to get pushback from insurance. Kristen, our wonderful social worker that does all of our insurance reviews is in constant communication with families about, hey, your insurance only gave me this many days at a time. I just want you to be aware. We're kind of doing this to try to push it ahead of schedule. But there is no end cap to it. It's when we see success. And kind of to jump back to what you were saying about puberty and how difficult it is, we do, for families that are open and willing to kind of have the discussion, we do actually offer a fairly robust kind of not sex ed, but masturbation education for patients who are starting to show interest in that in inappropriate places, on the playground, on the floor, in school, in the dining room, working on public versus private, and how to be safe about it, what is appropriate. And we've done a couple talks with some other facilities on what we do, because it is awkward and not many people want to touch that subject. But here we jump right in for families who are willing to have that conversation with us, to try to get ahead of the game and try to help their kiddos have success across the board.
Yeah, that's super important. Maybe we can have you back to really actually kind of focus on that at one point. We do get a lot of questions about it, and you're right, it's such a taboo topic, even within our community. But, these adolescents become adults, and a lot of their behaviors, whether it's aggression or property destruction or sexual behaviors, though they are not doing them in any kind of way with an intent to harm, once they become adults, how that's interpreted and what consequences come from that is really a scary thing for a lot of families. And so if we can address that early on, and there are responsible, dignified ways that we can address those types of behaviors so that it doesn't lead to more overly restrictive environments for them as they become adults. So it really is important to have a professional guide you in those behaviors as early on as possible.
But we're happy to work through that. For some families are not ready for it yet, and we totally respect that. But the families that are, let's jump in.
Yeah, absolutely. Absolutely. I'm not seeing another question we have in the chat. Thank you so much for all of this important information. We appreciate it so much, and truly we do. So, I will close it out here. Making sure. Yeah, no, I don't see any other questions, but we will have this up on YouTube. It'll be available for replay. We'll go ahead and put the information on how to get in contact with the hospital for special care if you think that this might be a good fit for your child and you want to give it a call. And I love that you have a social worker who's helping to kind of, because it's a lot of logistics of dealing with the MCO and your employer and the school and all these things. That's really a critical role to have when you're talking about an out-of-state placement like this. So it sounds like you have an amazing interdisciplinary team there, and we really appreciate you coming on, sharing with, oh, wait, Pat Miller is also saying thank you. I saw the little red button, but yes.
Oh, perfect. And thank you so much for having me. We love connecting with the community as much as we can, because not everyone knows what we do, or we sound really scary because it says inpatient. So thank you so much for letting me come and tell you.
Thank you. Thank you so much.
Of
All right.
course.
Good night, everyone.
Good night.